Thank you, أستاذ فرقد, دكتورة فاطمة, دكتور عبد الرحمن, involving me in this beautiful morning with this beautiful gathering.
أهلا وسهلا.
أهلا بكم. Okay, I will talk about motor evoked potential in this gathering. The motor evoked potential will be my topic. أنا دكتورة سيفان جبار من أربيل, clinical neurophysiology. And I'd like to greet everyone who are attending this meeting. Okay, it was شلون اسوي شو اسمه slide. It was found that stimulating the anesthetized patient's skull with a high density current can stimulate the cortical neurons, and subsequently the stimulation volley can be transmitted through all the motor pathway and recorded from the muscle. And this is the base of motor evoked potential. Stimulation, the most stimulating cortical neuron, recording from the last part of the motor system, which is the muscle. When you go to perform motor evoked potential, it is essential to go through anatomy. Like all other investigations in our branch, it is the anatomy of the area you are working on is an essential part to know how to interpret your work. So, anatomy of the motor cortex in human consists of different parts. The motor cortex in human, the motor system in human have a motor cortical part and have a tracts. The cortex have tracts and spinal cord, and have the peripheral part, which is the alpha motor neuron, and down into the spinal nerves and roots and plexus and nerves, and then after that the last thing, neuromuscular junction and the muscles. The motor cortex, there are many areas in the frontal lobe that are involved. And the motor cortex, the most important of them, which is the main controller of voluntary action, is the postcentral primary motor cortex, the precentral gyrus. It is a part of the frontal lobe which is involved in the performing voluntary muscle action in all human body. Okay. The other parts of the frontal lobe that communicate to do this and to adjust these movements are the premotor cortex and the supplementary motor cortex. These are all in the frontal lobe, one lying anterior to other frontal eye fields, and inferiorly in the frontal lobe there is an area called the Broca's area, which is involved in speech production. So these are these few parts are the cortical areas which are responsible for the motor function. طبعا we don't forget that the somatosensory cortex, part of the parietal lobe, also it has a good contribution in production of voluntary motor movements. The functional unit of the primary motor cortex are the cortical neuron. And the cortical neurons, in the simplest way, they are laminated. They are arranged in layers, in 6 layers. Layer 5 of them, it is the largest cortical neuron size layers. It is called pyramidal layer. These are the layers which are involved in the voluntary action. These are specialized cells that have different types of connections with themselves, with the adjacent areas. They have connection with the apical neurons, the other layers, let's say, and they have connection with the spinal cord. And they are the mother cells of production of the motor movement in the cortex. They are corresponded to the Brodmann area 4, and some of them, just to remember it, it is called bed cell. If you see when you read the motor cortex, bed cell, it's also a pyramidal type of neurons that have specific functions for specific motor action. And these pyramidal neurons, they are arranged not in a layer only, they are also arranged in a pattern that they form a map of a human body distributed over that cortex. It is called homunculus, a human homunculus. So the other part, this was the primary motor cortex and the functional unit, which is the cortical neuron, layer 5. Okay, there are other parts which also involved, we said, the premotor cortex, which is anterior. This is the area of planning and responsive movements in response to stimuli. There is the frontal eye field. This area is involved with the voluntary movement of the eye balls. The Broca's area is involved with the production of speech and the muscles that are involved in speech. And the supplementary motor cortex, it is the area that is involved in preparation and planning, also with the premotor cortex, and so on. Now, the other parts of the other part of the motor cortex of the motor system after
راح
that is
نقطع
the
بعد دكتورة
descending.
سيفان. الآن
عفوا
كان خلينا بالفول سكرين مود.
قرب.
الفول سكرين مود اللي جوا مأشر عند الشيء صفر.
ها ما مبين السلايدات.
هذا يعني هو بصف المكان اللي أشرتيه قبل شوي.
وين؟
هو انزلي للأسفل.
اوكي.
للأسفل على اليمين. على اليمين بعد. على اليمين على اليمين. لا.
better.
لا بعد أكو على اليمين آخر شيء. آخر شيء بعد على اليمين. بعد هذه.
هذه
دوسي.
like this. قايل من البداية. anyway the part الجزء الثاني. الجزء الأول كان الكورتكس، الجزء الثاني هو descending tracts. The descending tracts they are the tracts, let's say the axons of those pyramidal cell which are connecting to the next part of the pathway. The descending tracts they have two types, two main types. That originate directly from the pyramidal cell. We call it the corticospinal corticobulbar tract or the corticospinal tract. This is our scope, because we can assess the integrity of these directly, the corticobulbar and corticospinal. The other type of tracts that are descending are tracts that are coming from the brainstem nuclei. We won't go through them because we cannot directly assess their integrity and the function. The descending tracts, they are the pyramidal cell. After they come down and will be packed in the deep areas in the brain internal capsule, they will go through the brain stem, the pyramids of the medulla, and then decussate, and they will go into some of them decussate, of course, and will go into a spinal cord. This is what is called a corticospinal tract, and of course that from the cranial nerve nuclei will go. That's the portion of the tracts that will sign up to the cranial nuclei. It is called the corticobulbar tract. And that which go into the gray matter of the spinal cord is called the descending corticospinal tract. The corticospinal tract in the lower part of the medulla, most of them will decussate. And this is what we call it the pyramidal tract decussation or pyramidal decussation. So they will go to the other side. And some of them, that part of the corticospinal tract that go to the other side is called lateral corticospinal tract. Okay. And the part of the corticospinal tract that do not decussate, it will run anteriorly in the spinal cord. That is what we call it the anterior corticospinal tract. These two tracts are of specific importance because we monitor them and we can get responses from them, and we can assess their function and integrity continuously during operations, any operation around the motor system. And indirectly, we can assess the other tracts through them. Okay, so corticospinal tracts, the two types, the anterior and the lateral. Like that, how the pyramidal cells, they are laminated in a layer, and the layer is further arranged in a map on the cortex. The tracts and the anterior alpha motor neurons, which we call it anterior horn cells, these are also are distributed like a map. So there is a map in the spinal cord, white matter, exterior white matter of the spinal cord, which is the map of the corticospinal tract arrangement according to human body. Like we see in the picture, here we see that the hand, let's say, and the forearm, distal forearm, they are located most laterally from the exterior white matter of the spinal cord. And we see that also the hand on the forearm on the alpha motor neuron representations level, anterior horn cell level, they are located most laterally and anteriorly, while the proximal part of the body, they are more going toward the center of the cord. And we will find later on, I will tell you what we can get benefits from these points. These anatomical points at every level of the motor pathway, we can get practical benefits from them when we do our work daily. Now, And let's before going to the physiologic characteristics, the last part of the motor system in the human, I didn't go through it. Most of you are in a great proximity with the reading sources about it. It is the alpha motor neurons and the roots and the nerves and the plexus and the neuromuscular junction and the muscles. So those are the peripheral part of the motor system. And what we mentioned was the central part of the motor system. Motor evoked potential is assessing integrity of the peripheral and the central part of the motor pathways. Okay, now I want you to remember these properties in a I will go through it in a very quick details, because these we can get benefit from them in our daily work inside the theater. There are some properties of the activation, some physiologic properties for activation of the cortical neuron, the character of the activation and the type of the type of the responses that is produced, and how the force and the contraction is produced within the motor pathways. The cortical neuron have a summation character and a size principal character. The summation character means what? Means you some number of the unit that you activate from the cortical neurons. يعني larger number of cortical neurons you activate, you will finally get better force of contraction. Okay, so larger number of units, larger force of contraction. Okay, force of contraction, if we translate it neurophysiologically, it's the wave that you record. So if you stimulate larger units, you will get better response. And the size principle is the small motor units will produce small force of contraction, and the large motor units will produce large force of contraction. And I will repeat it, the force of contraction means better contraction, better muscle response, more chance to record. One of the other characters is the summation properties. Which means summation property? If you stimulate repetitively, the contraction that is recorded, they will have a cumulative effect, one over the other. This is a muscle property. I remember the Stafford gave us the lecture of the muscle fiber properties when we were students. The temporal summation. The spatial summation, we can get benefit of that also. The spatial summation is what? Is when you stimulate larger areas, inputs from separate location, they will have also a cumulative effect on on a neuron. So we can summate this larger area with repeated stimuli, so better chance to get response. Okay, why we are getting benefit from these properties of force contraction and muscle? Because you are working on an anesthetized patient, and the anesthesia means synaptic block. Anesthesia means cortical neuron suppression. Anesthesia means drugs that affect the nervous system directly. So it is these properties that made us we can record from an anesthetized patient. We have also synaptic delays, which means what? If I translated the clinically to you, synaptic delay means more synapses you have, more chance of delay of conduction of your action potential. So less chance of recording good responses. And of course, the excitatory and inhibitory postsynaptic potentials of cortical neurons, which are stimulated, any cortical neuron will, when it gets stimulated, it will produce excitatory and inhibitory potential. When the excitatory potential accumulates, and they are graded, also a graded response, fortunately. When they are graded to reach the level of the threshold, the cell, and across the threshold, the action potential will be generated. So these properties will act good and not good on the response that you are going to record and interpret in the theater. Okay, now we will start motor evoked potential. When we want to talk about this type of the test, which is the gold standard investigation in anesthetized patient to assess motor pathway in any surgeries around the motor system, Motor evoked potential, we should mention the person who discovered it in early 90s. It was a neurosurgeon named Kleinfeld. Many of the procedures inside the in IOM are named after his work. He worked on stimulating the upper motor neurons of the human cortex, of course, the somatosensory cortex also, and record from the muscles. And he tried also record from the spinal cord, and successfully he did. So we get the benefit of that. This current, if I give a high voltage current to the skull, it might go through the pyramidal cell and stimulate them, and it might go through corticospinal tract and stimulate them, and I can record from the muscle, even when he's anesthetized, the patient is anesthetized. So methodology, how to do it. We have types of motor evoked potential. Transmagnetic and electric both were used intraoperatively, but the transmagnetic is no longer practical. And the transelectric type of motor evoked potential, either you stimulate the descending tract, either you stimulate the skull, and the stimulation hopefully go through the cortical neuron, and the signal will be transmitted, or you stimulate directly the cortex, which is called direct cortical stimulation, and you record. So when you stimulate cortex, you bypass the skull and skin and CSF and dura. Or you stimulate the descending tracts, which is the epidural stimulation. You descend, the corticospinal tract, you stimulate the corticospinal tract, and either you record from the muscle or you record from the other part of corticospinal tract, to spinal or spinal to muscle. These are all methodologies to perform evoked potential from the motor system, to acquisite evoked potential from the motor system. Each of them has its limitation and its advantage and its indication. Now, there is no contraindication for motor evoked potential. As easy as that. You should take care of the jaw contraction, forceful jaw contraction that occur during MEP. And this is done by using armor endotracheal tube, or by using some protective measure for the teeth, because excessive contraction of the jaw might hurt the teeth, or might hurt the tongue, or might cause, very rarely, jaw fracture. So you should be careful, but it is not contraindicated. You should be careful about children under 2 years because of the incomplete myelination, and the density of the current that you need might be high. You should take care about pacemakers because of direct current transmission. You are giving a very high voltage. You cannot control the direct transmission of the current to the skin and the adjacent area. You should take care in cochlear implants. These patients with these you will have to off the devices, like as in vagal nerve stimulation, deep brain stimulators, and so on. Any operation that goes around the motor pathway, you can use motor evoked potential to assess the integrity of that pathway. From the neurosurgical operation, the tumors, intramedullary cortical resections, aneurysms, arteriovenous malformation, tethered cord, and so on. And from the orthopedic surgeries, deformities and cervical spine decompression, trauma, fracture, tumor, and so on. In vascular procedures, we can get good benefit of motor evoked potential, especially in aortic aneurysm, because the anterior cord will be directed to ischemia in these vascular procedures, and most of the patients were previously they were paraplegic or quadriplegic. And in carotid and arterectomy also you can get benefit from the motor evoked potential. Now and in aneurysm coiling and spinal IVM procedures, embolization, with also peripheral nerve reconstruction and other peripheral nerve surgeries. Now, how we record and how we stimulate. 1020 International System of Electrode Placement is used to address some important points that is presumably represent the primary motor cortex, the precentral gyrus. C1, C2, C3, C4, C5, CZ are used. C5 and CZ in a specific situation, not routinely, but C1, C2, C3, C4, what does it mean it's used? It means that when you are performing motor evoked potential, routinely you should accurately point these 4 point, point these C1, C2, C3, C4. It is the same as in EEG. Why we take meticulous attention to stimulation points in MEP? Because the site of the active cortex is very limited. It is not like SEP. In somatosensory evoked potential, wherever you put your electrode, you will get something. You put it exactly on the postcentral gyrus, you will get the exact negative waves of 10, 20, 10 and 20. You put it exactly on the contralateral on the let's say subcortical area, you will get exactly the thalamic responses. But if you does not put it exactly in that, for example, if you put the response of left upper limb in somatosensory on P4 instead of C4, you will get a response. It will not have the typical morphology. We will show you in videos how measurement differences will make morphological differences in the way, but you will get a response and you can depend on it and you can analyze and interpret. But in motor evoked potential, it is not like that. You go 1 centime out of your active area, you will not get motor evoked potential. You will make the patient jump over the bed and you will not get any potential. So stimulation points are meticulously important in MEP. CZ and C5 are used for a specialized. CZ in MEP is not the original CZ in 1020 in EEG. It is 1 centime behind. And C1, C2, C3, C4, it is either exactly the same in EEG or you go 1 centime front. These are all made to hopefully go directly on the cortex, on the precentral gyrus. Okay, and the impedances should be less than 1 kilo ohm. Skull has highest impedance. You cannot, in motor evoked potential, you are giving, let's say, 300 volts. So you cannot control the current spread directly on the skull. That's why we, in cochlear implants and pacemakers and these things, we have problems. So you cannot control. You need to obtain optimal response. You might manipulate your stimulation parameter inside the theater. So in stimulating the C1, C2, C3, C4 areas, you have a high chance of direct muscle response and direct current spread to face and neck. This we should take it in our consideration to interpret carefully, because sometimes you get responses from direct current spread, not from stimulation of the pyramidal cells and the corticospinal tract and on, not through the motor pathway. You will get a response directly from the skin spread. So this also should be taken in consideration. Where depolarization occur. when you for example, when I stimulate in NCS, I stimulate the median nerve, so the depolarization is in the median nerve. It's in the fibers of the median nerve, isn't it? It is. So, but in MEP, there are 3 sites within the motor pathway that can be stimulated. Not necessarily only the pyramidal cells of layer 5 can be stimulated. So stimulation reaching the cortex, stimulating the layer 5 of the cortical neurons can give me an motor evoked potential. Stimulation reaching corticospinal tract in the corona radiata, somewhat deeper, can give me, can stimulate the corticospinal tract, and the volley of stimulation can go on down to the motor system, so I can get response from them. And if I go on and give a very high current, I might even stimulate the corticospinal tract at the brainstem, at the medulla. So can you imagine how Can you imagine the importance of this? So not every motor response that you achieve in operation is from the pyramidal tracts. It might be from the corticospinal tract. It might be down in the brainstem. For what clinical application of this point is what? Is that when you have higher lesions, when you are working on lesions above the level of the brainstem, your motor evoked potential might not be reliable for interpretation. I don't know if the point is clear or not. يعني when you have a lesion above the brainstem, you don't depend on motor evoked potential alone. Why? Because my stimulation part, because I have a site of stimulation that can give me a motor response, it is in brainstem. And also I have it in coronary data and I have the and I cannot know which is which. But the intensity of the stimulation suggests the site. More intensity is more deeper. But it only suggests. So we should take care of this. Optimal responses are when corticospinal tracts are stimulated, which is the moderate intensity. Not too low, the response will be faded. And not too high, you will bypass most of the cortex. So that's why, in general, motor evoked potential does not have that value in higher cortical lesions. For, let's say, cortical space occupying lesions, we don't depend on motor evoked potential. But in lower than brainstem, it's a very sensitive, specific, gold standard investigation that is used. And motor evoked potential is an anodal. It is an anodal stimulation. What does that mean? It is not like the NCS. In NCS, the current is going through is coming out from the cathode. In MEP, also this point has a detailed physiologic basis, and it is related to the organization of the cortical neuron and their physiologic properties and physiologic differences from the peripheral nervous system. We cannot go through it today because it's a very long story. But the anode is going to stimulate. What does that mean? That means if I stimulate it with a C3 cathode, C4 anode, okay, most probably the responses will be recorded from the right upper limb. Why? Because my C3 is anode. And if I increase this, it is found that if we increase, of course, the current intensity, we will increase the number of units that we talked about, number of units stimulated, we will increase the force of contraction, we will increase the excitatory postsynaptic potential, will increase the summation, and the cathode also will act as the cathode also will act as a stimulating electrode. So both will act as stimulating electrode. So I might have both responses from upper and lower limb. But in general, when you stimulate at moderate and low intensities, only the anode is acting as active. So it is predicted to get response from the contralateral part of the body. These details, I want you to take care of it because we can let's say get benefit from it in the work. Okay, there was a study done to predict the current densities in the brain during transcranial electrical stimulation. People who perform motor evoked potential will notice that there is a wide variety of parameters that you can get the evoked potential with it. One of the causes of variable current intensities that is used is the density of the tissues and their impedances. For example, even CSF has an added impedance. White matter has an impedance. Blood, skin, gray matter, soft tissue. We see that the bone is the main barrier, but also there are other barriers that might add onto the impedance. So if we translate this into a practical terms, your electrode, if it is not on the cortical sulci, sorry, it's on the cortical gyrus, it's on the sulcus, you might need higher current. That's why we see that sometimes small manipulation of the stimulating electrode will make a very, very big difference in the responses that's recorded because of the current densities in brain during the stimulation. You might put your electrode here. For example, you have the skin, you have the skull, you have the CSF, you have the dura mater, and then finally you have this small portion of the cortex. Is my pointer is clear? The pointer is clear?
Yes,
Okay,
Dr.
are you
Sivan,
hearing me? واضح? Okay. And if you put your electrode here, you will bypass the CSF. CSF also has high impedance, and you are nearer. And you have a larger area. So the response from here is totally different from the response. And when I see it here, it is a very small area. It's a very small adjustment. So don't be frustrated when you do MEP. MEP in stimulating electrode, it's a story. Okay, the sites we said we'll mark it like this, like an EEG, like in any other EPs. It is better to it is better to implant your electrode in all 4 points, even if your scope of operation was not both upper and lower. Why? Because C1, C2, they are more liable, will get your response from lower limb. C1, C2 montage. And C3, C4 montage will stimulate the upper limb, and which is logic because if we look to the map of the primary motor area, it is lower limb and then upper limb. Upper limb will be in. And C5 lower down here will stimulate the area of the face. We can use it in corticobulbar evoked potentials when we take CZ to C5 montage. But it is better to take all 4 points and then manipulate according to the responses you get inside the operation in order to get better response, more waves, more potentials, and better analysis and better decision making. So this is according 10-20. The patient is prone, the anterior part, and the lower 4 electrodes, C1, C2, C3, C4. You record it, you put it, you point it, you measure it, and then Allah Karim, in the operation, what you get. This is only C1, C2 montage. The recording is by these electrodes, which are Crook-Screw electrodes. They cannot be pulled out. They have less current density and they have lower impedances. You can use needle, but you can't use surface electrode. Either needle or Crook-Screw. Parameters of stimulation. Okay, there are different parameters. Each of them are pointing to different parts of the response that you get, and each part and each muscle and each body region you must manipulate the parameter accordingly. In general, the duration is 75 microsecond, and the rate within the rate, the frequency. There are some arguments. What I want you to know that the rate is the number of your train that occurs within 1 second. Okay, that's why you say my rate is 1 hertz or 2 hertz. So you give 2 trains in 1 second. Well, it is hertz in unit, but it is totally different from the frequency of the stimulation. The frequency of the stimulation. Do you remember how we calculate the frequency of a burst of a myochemic discharge in EMG? It's the same. The frequency of a stimulation is the number of the stimuli and it's the time from one stimulus to another within the train of stimulation. You have, because the patient is anesthetized, we use train stimulation, and it's a multiple stimulation, the motor evoked potential. When you give 5 train, the time between between stimulus 1, stimulus 2, stimulus 2, this is the frequency of stimulation. Okay, while the something you see on device, it's 1 hertz or 2 hertz. This is not the frequency of stimulation. It is the rate of your train. Okay, and the frequency and stimulation and the interstimulus interval logically, if the stimulation 1 and stimulation 2 have more time, okay, we say that has a long interstimulus interval, so it is a less frequency. Is that clear? You can stimulate the motor cortex from 1 to 9 pulse, okay? And best responses are get with 5 pulses. The time between the pulses is important. And the time between the pulses is the frequency of stimulation. And the time that this train will come in a second is the rate of stimulation. So when you less time between the two stimuli, when you have less time between the two stimuli, so I will have a higher frequency stimulation. So when I say the ISI is 3, it is expected to have a lower frequency than ISI is 1. Is that clear? And the other parameter of stimulation is the intensity. Okay, the intensity, it is the high voltage current that you give. It is very, very variable. There is no, you can get motor response sometime from 50 volt. You can get first motor response from 200 volt. There are many things that it depends. First is the motor responses from the muscle, the myogenic motor evoked potential. These are a polysynaptic. It depends depends on whether that current that you give over the skull will pass everything smoothly and go to the muscle and cause the action potential to reach the muscle and activate more units. So it depends on the health of the nerve, health of the plexus, presence of degenerative disease, presence of chronic diseases like diabetes, weight of the patient. It depends on even the character of the neuromuscular junction, the healthiness of nervous system. So intensity is variable, but rate and frequency and duration, you can have a role in it. So that's how we can get benefit from temporal summation of the cortical neuron stimulation. We said that it's a cumulative, a graded response that if I stimulate it repeatedly, one after the another, I will temporally summate. I can summate the responses and make a better force of contraction and make a better response. So the force of contraction at 200 hertz is less than force of contraction at 400 hertz in the same patient. Why? Because the temporal summation character of the cortical neurons. But you don't forget that you should not stimulate at a very high frequency too quick, because if you stimulate too quick, your stimulation will go into the refractory period of the action potential and it will be failed, be zero. And you should not go too long, too slow, because when you go too slow, you will not have the response will be delayed at the synapses, so you cannot get benefit from this temporal summation. The responses will be degraded and fade. يضيع cannot be added. That was the stimulation. Recording, as you are stimulating presumably all the corticospinal tract, it is theoretically you can record from everywhere, but But it was found that specific muscles have a specific pool of alpha motor neuron in the spinal cord. And responses are different from one muscle to another. And we add to this also the accessibility of the muscle, whether my needle is near or far, or whether the muscle is covered by fat or not, whether the patient is, and many other co-founders. It was found that small muscles of the hand have a very large pool of motor neurons, alpha motor neurons in the anterior gray horn. So we usually use them because the probability of getting response from small muscles of the hand is very high. And it was found that long flexors of the foot muscles have a very large pool of motor neuron in the gray matter of the spinal cord. That's why we love tibialis anterior. And the recording is by these needles. There are different sizes, different types, different morphologies for deep muscle. And logically, you think of it, if I have small muscles, I will record with small needles. If I have deep muscles, like gastrocnemius, iliopsoas, rectus femoris, I will use longer needles. Surface electrode is not used. Needle electrode is placed inside the muscle, and compound muscle action potential is recorded from it. You need to cover a good number of muscles to get good data, to analyze better, to make decisions better. At least if you are doing a motor evoked potential for a pathology that affects the motor pathway from the cervical region, it is at least you need to 10 to 12 muscles record to cover all the possibilities: upper, lower, proximal, distal. The protocols to record from the muscles differs as if you tell your the dress according to the patient. According to the site of the pathology, the type of the insult, you choose the muscle. In some pathologies, you need to choose the muscles according to root innervation. In some pathologies, you need to record the muscle according to nerve. Others, you need to record the muscle according to distal proximal. It is like the EMG. You tell the dress on your patient. You don't make them wear the same dress. The usual motor evoked potential can be recorded at 10, 100, 100, 200, like EMG, and the sweep speed is 10 to 20 milliseconds per division to see what's going on. And when you are looking to a motor evoked potential, it is expected that you look for a polyphasic of variable amplitude. More phases, more amplitude variation, healthier muscle. Less phases, less amplitude variation, you should think. And latency is somehow fixed. Latency of the response. You see that there is a fixed latency, almost fixed latency, but the amplitude is totally variable from one response to another. This is the motor evoked potential. This is what you look for on the screen. That was the multiple pulse when you stimulate the cortex and record from the muscle. Now I will talk about briefly the D wave. D wave is stimulating the cortex and recording from the corticospinal tract. So I won't go to the peripheral part of motor system. I will stay in the central part of the motor system. This type has advantage and disadvantage, and the muscle type has advantage and disadvantage. The muscle type will assess the integrity of whole the motor system, while this type assess the integrity of the central part of the motor system. Before reaching the alpha motor neuron D wave, it's called direct waves. Either you stimulate the spinal cord and record from spinal cord, or you stimulate the cortex, same as the muscle response, and you record from the spinal cord. Each of these types have their specific indication and limitation. Which is good about D wave, it is not influenced by non-neurosurgical factors. It is not influenced by patient with muscle disease. It is not influenced by patient with liver disease and fatty muscles. It is not influenced by patient with neuropathy. You will bypass everything. You will bypass some anesthetic drug that acts synergistically with intravenous anesthetic drug to block the neuromuscular junction, not the relaxant. I don't mean the relaxant. There are some specific drugs, they will act synergistically with the anesthetic drug and they will block the muscle. All those factors, you will bypass it by this, the direct response from the spinal cord. Okay, but it is invasive. It needs laminectomy specifically for the electrode, and it needs insertion of the electrode over the spinal cord. It's used in specific indication. Dr. Adai talked about a patient with SMA, patients who have neuromuscular disease. Neuromuscular يعني in the peripheral part. And those patients with a neuromuscular disease, not small proportion, good proportion of them will have spine deformities. They will have, let's say, a tendency to form tumors in the CNS. Those patients, it is better to be monitored with D-wave responses. Why? Because you bypass these problems, small muscle atrophy, myopathy, degenerative change, fatty fibrosis of the muscle. You will bypass these patients, even you will bypass the defective regenerative neuromuscular junction. For example, SMA is denervation, reinnervation. You will bypass these. You will directly take the response from CNS. And filters are the same. And the sensitivity, the D-wave response is a very tiny response. It is like SSEP, a little bit higher in amplitude. And latency also variable according to the tumor, according to the compression on the cord. But it is usually acquisited by averaging. It is a motor response, but it acts like somatosensory. And we will see in the last part of the meeting, the videos, how we record D-wave. Okay, in motor evoked potential, we have other models of modification and stimulation parameter. You see that everything is about stimulation, everything, because of that, the reasons we mentioned. There are a type of stimulation, it's called double train stimulation, which means that I will prepare the cortical motor neuron and then I will stimulate them. I will prepare them by 2 pulse and I will stimulate them by another 5 pulse. So train 1, train 2, and I will give them a period. It's called double train stimulation. There is another type which is called quadrupolar stimulation. Quadrupolar stimulation is when you get the benefit of the spatial summation character of the cortical neuron excitation. You will stimulate by 2 electrodes, active 2 electrodes, cathode anode. So you are stimulating a larger size of motor neurons, a larger area of motor neurons. These are also techniques that can be used in patients with neuromuscular diseases and patients who have difficulty in attaining motor evoked potential, but they are not pre-op. They have pre-op abnormalities. You can use these techniques. Thank you for your attention.
شكرا لك دكتورة سيفان. هسه بس ابقي ويانا وننتقل اذا اكو احد عنده سؤال من الحضور ان شاء الله حتى نقدر نوجه السؤال لك. تمام ان شاء الله. اكو احد عنده سؤال دكتورة سيفان؟ الموتور ايفوكت بوتنشال. تمام دكتورة. يعني الزملاء الموجودين هنا ما عندهم سؤال ان شاء الله. نشكر دكتورة سيفان على احترافية الطرح. نشكرها على الاهتمام بأدق التفاصيل.